the DFR staff. We've got some new folks who have at least joined us on our side, and it's also been we last met in September, so it's been a few months since we last came together, and thought that might work out best. So we'll start with the RAC members. If you want to unmute and just say your name and who you are representing, that would be helpful.
Good morning, Dan Toma, representing Moda Health.
This is Chris Bonaff with NAMI Oregon.
I'm Bennett Garner with, go ahead.
Go ahead. This is Antoinette Watcher, representing Cambia Health Solutions.
I'm Bennett Garner, representing the Oregon Psychiatric Physicians Association.
Gary Holiday with Pacific Source Health Plans.
Jennifer Baker, Providence Health Plan.
Melissa Todd, representing OIMHP.
This is Laura Curtis for Basic Rights Oregon.
Lauren Bowling with National Association of Social Workers, filling in for Dan Cushing.
Hi, this is Tim Clement with the American Psychiatric Association on behalf of the Oregon Psychiatric Physicians Association.
Any other RAC members would like to introduce themselves?
Yeah, sorry for being a little late. Rachel Wiggins-Emery here on behalf of COPAC, which is the Licensed Professional Counselors and Marriage and Family Therapists of Oregon. Thanks.
Yes, can you, if you can hear me, this is Jim Davis. Can you hear me? Okay, I never can tell. This is Jim Davis. I chair the Oregon Older Adult Disability Behavioral Health Advisory Council, and I also chair the Oregon Disability Commission, and represent a number of different senior state and national senior advocacy groups. Good to be here.
Wonderful. Well, thank you to all the RAC members for being here and all the interested parties who are also on the line. Really quickly, we'll go through the DFR staff who are in this meeting. Like I said, we've got a couple new, some new faces and some returning faces. So I'll start. I'm Cassie Susi. I'm one of the senior policy advisors at DFR.
Hi, I'm Emerson. I'm a senior health insurance programs analyst for DFR.
Hi, everybody. My name is Tasha Sizemore. I'm the Life and Health Program Manager for DFR.
This is Spencer Peacock, Data Analyst for DFR.
Hi, everybody. My name's Brooke Hall. I'm the newest member of the team over at DCBS. I'm a senior policy advisor with the team, and I was previously over at the Department of Human Services, so I recognize some of you from the work that I did over there.
Rick Berry, DFR, Lead Forms Analyst.
This is Jesse O'Brien, Policy Manager with DFR, back from leave, but on the phone because my home internet is not working. Fun times.
And I am Karen Winkle, the division's rules coordinator.
Fabulous. Thanks everyone for being here. Wanted to start our meeting just providing some time for those who did submit comments to provide kind of a verbal summary, or if there's anything else that you would like to add for the RAC to hear. So we'll go through starting with Pacific Source. So Gary.
Great, thanks, Gary. Hey, my comments generally is, the first two comments were follow-ups to our last rule advisory committee. In one of them, there was discussion about removing a reference to ORS 743.8.68. I thought we were going to remove it, but it was still contained in the proposed rules that were filed. And I didn't know if there was a change or why that was still occurring. The other comment I had is similar, that there was another proposed rule that, we talked about the last Rules Advisory Committee. We're going to remove one of the subsections in there, but yet it still remained in the filed draft rules, and wondering if something occurred there to keep it in. And then my final comment was just basically when going forward for other sections to discuss during the rulemaking process, it was regarding the definition of a behavioral health condition. It would help if we can get it down to a diagnosis code of some sort. And then in regards to the sponsorship of education programs, can we define that a little bit better in the rules, or what is it, what's the intent there if we're not going to create rules around it? And those are my comments. Thanks.
Thank you, Gary. And I will just briefly mention that we are going to take a look at the recording from the last meeting, and we'll get back to you and the other RAC members if kind of in response to your questions about the proposed language, and then also that it'll probably be following the public hearing when we get all the comments and kind of review all of that.
Great, appreciate it.
Yep. All right, we will move on to Providence. So Jen.
Hi, thanks for the opportunity to share our comments. So the first part of our comments were operational in nature, and just a lot of clarification questions on the draft data reporting template. I'm just looking at many of them now, and these came from our operations folks. So if you, there was some stuff that I needed clarification on what they were asking. So if the DFR would like to discuss some of what we're asking, more offline, I don't want to take up too much time here. I'm happy to do that. But, they went sheet by sheet and said, are we to report distinct claims, or do we report service counts, claim length, like, again, stuff that's minutia that we don't want to take up RAC time with. So it'd be great to get those responses for all carriers. So I think we can have a good level set there. And then, so obviously for future discussions, we wanted to clarify, we wanted DFR to clarify the legislative intent of Section 8.5C, which would allow for appropriately objective and evidence-based review criteria tools for clinical review. And we are asking that the DFR make it clear that based on the language of the statute, it allows third-party vendors to continue doing clinical review in addition to if we wanted to do a professional association standard as well. And that's it.
Great, thank you. And I'll preview probably a point that will come up later in the RAC meeting, but I think we're going to set up some one-on-one meetings with all the insurers just to talk about reporting and what clarifications you all might need from us. And so that's probably forthcoming from us or from Tasha later in the meeting or after this meeting in terms of getting ready for that March 1st reporting.
Can't wait.
More meetings with us.
Thank you, Kathy.
Yeah, we'll move on to the Behavioral Health Coalition comments.
Thanks, Cassie. So we submitted comments on behalf of both the providers and the advocates that worked very hard to pass this bill. This session focused specifically on the provisions of the bill that still need rulemaking, and just wanting to be very clear and flagging what was included in the bill specifically for discussion and rulemaking. That includes the definition of timely access to care. That is a very complex discussion that we need to have, and we wanted to make sure that we could have it in a space with experts. We also flagged, it looks like the state of California a couple of weeks ago passed a law requiring 2-week access. I don't know if that works for Oregon, but just wanted to note that that is something that other states have looked at. Additionally flagged the needing for rules around requiring providers to use specific billing codes. A very long conversation that we're going to need to have around network adequacy. What does an adequate network look like? Also wanted to be sure to echo the comments, and I know Laura will get into them, the comments submitted by Bro around inclusion of LGBTQIA individuals. That is something that we talked about as a coalition during the session, but just didn't want to have yet another amendment to this bill. So really wanted to make sure it was addressed in rulemaking. And then both level of care, placement decision criteria, since it is a requirement that that carriers utilize nonprofit professional associations, if there can be a means of documenting that, and then having some very clear rules around for all other decisions related to medical necessity and utilization, how it needs to be made publicly available, because we think it's very important that members for plans are aware of sort of the criteria that carriers are using to make those utilization decisions. That is very high level. I really tried to focus on why we included it and not what we think the proposed solutions are, recognizing that that'll be a really good conversation that we'll have as a group. So thanks.
Thanks, Rachel. All right, so moving on to the Oregon Independent Mental Health Practitioners. So Melissa.
Thank you, Cassie. So, you know, our document mostly focused on section 512 and the which specifically talks about restricting a specific billing code for reasons other than medical necessity. And we really wanted to call that out because we're starting to see some things happening here in Oregon. I'm part of some nationwide networking groups with other therapists, and some of these practices have been going on in other states since as early as 2016, but we really haven't seen a lot of it in Oregon, and all of a sudden it's popping up, and it kind of coincides with you know, the work that we're doing, and I think it's very, very timely. And so we really just wanted to give you guys a background on CPT code changes that happened in 2013 and just subsequent moves by some insurers to restrict one particular billing code, which is 90837, even though the CPT manual doesn't single that particular code out in any way as being different than any other code. And, you know, in the last section, you'll we got very specific about some things that we're seeing in Oregon. We were contacted by a number of providers about efforts by Change Healthcare to monitor their specific use of 90837 and the effect that it was having on them, that they felt intimidated. And we're really concerned about this because, again, we've seen it in other parts of the country, and it's spreading now to Oregon. And we think that, you know, it's really just because statistical methods are used, that doesn't make it meaningful. And so identifying statistical outliers is not the same as saying that these particular people are doing something that's not medically necessary. And so we just really want some rules written to make sure that it's clear how third-party companies or insurers are monitoring behavioral health providers specifically, and for what reason. You know, is it just simply for you know, cost containment, or you know, is there something meaningful behind it that has to do with proper clinical utilization and medical necessity?
Thank you, Melissa. So moving on to Cambia. So Antoinette.
Hello, good morning. Well, our comments were very brief. We had no concerns about the NQTL template because it appears to closely follow the DOL's tool and guidance. But one thing that we urged going forward, that it remain consistent with the federal requirements and guidance. Also, regarding the draft DFR reporting template. We have no comments at this time, but we may be submitting some comments after this RAC meeting. Same with the other areas of the law that we think we would benefit from further clarification. We may be submitting comments after this meeting on that. Thanks for your time.
Thanks, Antoinette. All right, moving on to Dan with MODA.
Morning, thanks. So in spirit of kind of getting my timing backwards, I had submitted a letter way back about contracting processes and just ask that that be kept in mind as we move into any rulemaking related to the process of contracting. And then in going over the reporting template and comparing that with the rules, I found a couple of things that I wanted to call attention to. One of which is the role of reporting on out-of-network providers. My understanding of the intent of the bill was really the focus was on contracted rates and in-network providers. And going back and reading the text of the bill, it's not specified one way or the other. And so my feeling is that out-of-network providers are probably kind of out of scope, but if we are asked to report on them, which would be fine, that the reporting has to be separate from in-network and out-of-network, because if you combine those two into the same data set, it'll destroy any meaning that you're hoping to get from that data set. And then the second one, oh goodness, or the third was no, I guess that was, oh no, the main thing. In consulting further with our data analysts, they say we don't have the ability to pull the data that's the current rule is requesting on contracted rates. And I would hesitate to have a rule that we're not able to comply with, and just wonder if maybe a reasonable substitute for that. I didn't put this in the letter, but thought about it later. You know, what's your standard? What's your standard go out rate, which seems to be really, you know, getting at the purpose of wanting to know, are payers willing to invest in behavioral health system or behavioral health care? What our standard rate going out the door is maybe a more accurate measure of that than contracts for providers that haven't seen a patient in 8 years.
Yeah, we do appreciate the feedback in terms of how the reporting will work and kind of making it functional. So I think we'll continue that conversation in a little bit. Moving on to Basic Rights Oregon, Laura.
Thanks, Cassie. So we really just had one request in the document that we sent over that Rachel previewed for you all in the engrossed bill on the bottom of page 11, top of page 12. It lists out the populations of folks that need to be considered when determining whether or not there's an adequate provider network. And it does give the agency the authority to add additional groups to that list in rule. And we are requesting that LGBTQIA+ individuals are added to that list. We provided some language in there about what that could look like based on what we've seen Legislative Council draft in bills in recent years. You know, that list kind of changes, but that's kind of the most consistent we've seen as a way to refer to that community, and obviously provided some reasoning that we think that it's really important that folks have access to affirming providers no matter where they live in Oregon. So that is really the summation of our comments.
Great. Thanks, Laura. And thank you, everyone. Again, just to reiterate, it's really helpful to receive this feedback, both in terms of the reporting template and how that will work for your teams, or having that feedback from the people who will be pulling the data for you to report back to us. And then also on what we should focus on for this next phase of rulemaking. For the remainder of our time, I want to give some time to talk about the reporting template, knowing that I think we will be having some offline conversations with the insurers to just make sure that if there's any clarity that we need to put in the instructions, that we do that, and kind of talk through what any issues that you see on your end in terms of reporting. And obviously we can circle back with the RAC if there's anything major and significant that everyone should know about. But digging into kind of, there were the 2 points that I think came up about the contracted rates. And Dan, you'd mentioned the starting rate, or the rate that you go out the door with, and want to just kind of see if others have thoughts about that, in terms of an alternative for contracted rates, or what thoughts are from RAC members. Is that the right terminology, is like the starting rate, or yeah, would like to just kind of hear some reactions to that. Melissa.
Yeah, we, you know, at OIMHP, we obviously argued pretty strongly for the inclusion of both incurred claims rates as well as contracted rates, and we continue to advocate for that. We did a little bit of digging and interestingly found a commentary in the federal rules of the federal mental health parity law back in the register from, let's see, November 13th, 2013, where the comment really discussed how, you know, developing rate schedules is certainly complex, but that they did not believe that it was a good enough argument, that complexity was something that should get in the way of transparency. And so the federal position seemed to be that they believe that even when there are multiple rate schedules, that should still be compared for parity reasons. So we saw that, and just ultimately, you know, I don't know how all of these systems work, and but somehow providers are paid their contracted rates. When I submit a claim, the system knows what my contracted rate is, and so it's hard for me to believe that there is not some way to get to that data. It may be something that requires some upfront work, since it's not something that perhaps the insurers have had to access in the past. But I don't know if that's a good enough reason to say we can't access it now and we can't find a way to do it now for the purposes of complying with the law.
I'd like to ask a question about this, because I think I would guess what the answer is, but I'd like to ask the insurance representative. So I think most companies do have a standard contract rate that's what they send out, and then things get negotiated. So my question is it ever the case that the standard rate is higher than what gets negotiated? Or is it always going to be pretty much the lowest rate that you offer?
Jen, go for it.
Yeah, I mean, I don't know that I can give you exactly the answer you're looking for, but there's not necessarily a standard contract rate for everyone. It is, you know, there's so many factors that go into it, where you're located, you know, what the market rate is paying in the city of Portland versus this, you know, the small town of Burns, Oregon. So, I mean, there's, you know, overhead costs, and those kinds of things. There's just a lot of factors that go into how rate negotiations go into effect. And I did want to kind of respond to Melissa's comment about the 2013 federal comment was a comment and it was not a regulation. So it wasn't, I mean, even though there was a comment on that, it wasn't something, it sounds like, that had the effect of law. And that goes back to 2013. So, I mean, a lot has changed, right? The ACA went into effect in 2014. So many things are different now. And we continue to maintain that providing the contracted rate and the claims rate is duplicative and unnecessary, because again, just like Melissa said, when she submits her claim, the rate that she negotiated specifically is in that claim. However, there are going to be several, and then again, I think that this doesn't help necessarily providers, but there's going to be contracts for providers that don't see patients anymore. They don't have any claims. And so, their rate may be lower because it's an older contract. So I don't know how this is helping this issue, but that's kind of our position.
Melissa.
Yeah, just going back to one of our previous meetings, and I can't recall, it might have been the third meeting, where one of the reasons why we are interested in the contracted rates of providers who are not submitting claims is for the purposes of network adequacy and trying to understand why those providers are not submitting claims. And we sort of assert that it may be because, in some cases, because the rates are very low. They perhaps have been stagnant for a really long period of time. Perhaps they have actually been reduced over a period of time. And so the fact that if there are a certain number of providers in the network who are not submitting claims, we feel like their contracted rates is an important piece of data to take a look at. And yeah, that it's really because of the relationship with network adequacy. I did have a question, but it popped out of my head. I'll come back to it if it pops back in.
Tasha, I think you're next, and then we'll move to Dan.
Yeah, Cassie, thanks so much. I think, Melissa, the comment that you made there about the interrelationship between network adequacy and the payment rate is where my head was at. From a compliance perspective, I really need to be able to see, in order to better understand the network adequacy piece, I need to be able to see the interrelation between, those providers who haven't seen patients for a long time and their underlying contract rate, to understand that. So we had an offline conversation this morning at the division. Sorry to Brooke, who I didn't realize would be taking this over, but I'll fill you in later. Spencer and I offered to reach out to the insurers to talk about some of these data issues that and questions, because to better understand each of your systems and to better understand each of the limitations, I think is going to be really important to us. So I'm definitely hearing what you guys are saying, and I don't want to just dismiss the insurer concerns about the data and how to get at that. I think that that's something that we can take care of offline. And so for the insurers on the call, you'll hear about this more at IC next week, but we are going to offer some time with Spencer and I to talk about the data requests and how we can work with each individual insurer to get the information we need. So I just wanted to put that in there right now and just, kind of respond to the obvious connection that we're starting to see play in between network adequacy and rates. So I'm just going to pause there, and I think Melissa may have remembered her question, but that was all I had for now.
Yes, and so I guess my question, me being a behavioral health provider, I only see what happens from our end of things, and what it appears to be happening on our end is just that there's a lot of uniformity in the rate schedules for behavioral health providers, because we've kind of talked about this in the past. There isn't as much negotiating power if we're sole practitioners, whereas on the medical side, it may look really different. I'm not a medical provider, so I don't know exactly what that looks like, but they're part of maybe large medical groups, large hospital groups. There's more negotiating going on there, and I can certainly see how that might make things more complicated for insurers to access that bit of information on the medical side. But on the behavioral health side, there's a lot of uniformity, and even that to me is meaningful and telling and worth taking a look at.
Dan. Oh, you're on mute.
Thank you. So I think Bennett's question really gets to the heart of Melissa's concern, which is your standard rate your lowest rate? And I can only speak for MODA, but yes, it is. You know, we don't go out the door with something above the minimum that we want to pay. Now, there are going to be some cases where, like if somebody hasn't updated their contract in 10 years, their rate is likely to be lower than our standard. But the remedy for that is to get on the new standard rates. It's not like we're going to say, oh no, we like your 10-year-old rate structure. We're not going to put you on our standard rate. So I really, you know, again, I think that going for that standard rate does address the network adequacy concern better than looking at contracts that haven't been updated because the provider died or retired or just for whatever reason.
Rachel.
Thanks. Dan, I had a quick follow-up to your response. For your standard rate, does that deviate based on location? To Jen's point that, you know, there's a lot of things that are factored into what you offer to providers. Do you have a standard rate for Portland versus what you may have for like Southern Oregon?
MODA, we don't.
Okay.
It's the same state, right? Statewide, your location may be a factor in whether we're willing to negotiate up from there.
That's helpful to know. Thanks.
Melissa.
I guess I just have a question for insurers is, you know, we're using this term standard rate today versus contracted rate, and we haven't talked about that before. And so can somebody explain to me what the difference is between contracted rate and standard rate?
I guess since I brought it up, maybe I can. So standard rate is it's basically our default. A provider contacts us out of the blue, or we contact them because we just decide we're interested in having them in our network. It's the default that goes in the contract that we send out the door, and that gets and that's set through, you know, analysis, actuarial work, and budgeting, and all that kind of stuff. So it's, you know, we don't take a sort of a random scattershot approach. Well, we'll send this provider higher rates or this provider lower rates unless there's a specific reason to deviate from the norm. So the standard is what we're going to send out unless there's a reason to do something different. Contracted rate for most providers is going to be that standard rate. But, you know, Melissa, you talked about negotiating power. Some providers or provider groups have negotiating power, and they're able to get us up off of our standard rate to a higher rate. And so for that provider, that would be their contracted rate, whereas for another provider, their contracted rate would be the standard.
We'll do Melissa and then Bennett.
Thank you, Dan. That's helpful. And took a couple notes here. So I guess what it seems to me is, you know, you made the statement that for most providers, the standard rate is the same as the contracted rate. And I would say that that's probably very true on the behavioral health side and maybe less true on the medical side because of said negotiating power on the medical side. But again, you know, it's a difference. And so only looking at the standard rate, that means that we're going to be looking at different things between medical and mental health. And we're going to perhaps miss some of the higher negotiated contracted rates on the medical side. And I guess I just wonder, you know, how, on your end, and again, maybe this is back to Tasha, is just why is it easier to access the standard rate than it is the contracted rate, and why that's such a point of contention?
Bennett.
Well, actually, I think, Melissa, you make a good point. What I was kind of getting at is if we look at the standard rates, that's probably going to be a low estimate from the mental health point of view. But I would also ask Jennifer, I'm guessing that although you may slice and dice things, you have a standard rate for Portland for a LCSW. I mean, is that true, or there really is no standard rate even for geographic region and qualification? Or RAC rate, maybe using Dan's point of view, and I would call it the RAC
I
rate.
could check and see what our standard rate is. Some of the conversations we've had recently were, based on using the Department of Labor tool and how we can bring our contracting in line with 3046 and then the federal standard. So, but it does. I mean, let me turn the tables and ask you, Ben, do you think that independent behavioral health providers have the same overhead and costs for a medical office, as a medical office, as a family practitioner with all sorts of different requirements, plus malpractice insurance and other factors that go into it?
Well, so a couple of things. I think one of the comments was about using RVUs to establish rates, and RVUs supposedly address that issue. So I think that's kind of a straw man in a sense. I
would agree with you on that, but okay.
Yeah. So I will say that my own experience from when I was in private practice is that I frequently got a rate higher than the RAC rate, but there was always a RAC rate. I mean, I never reached out to an insurance company, nor vice versa, where there wasn't some standard offer. And then depending on the circumstances, we went from there. So you're
saying there is a negotiation process, though, for independent providers, which kind of goes against what was being discussed earlier and saying that there is no negotiating power.
Well, I would say that's true. On the other hand, in my case, I was a board certified child psychiatrist. That puts me in a whole different position than an LCSW or an LPC.
So there are different factors then to be considered.
Right. What I'm saying is there was a RAC rate
that can be a starting point, like a default, just like Dan had mentioned. I'm sorry, I don't mean to keep interrupting, but I want to continue this conversation because this is where we're at. And frankly, most behavioral health providers now are doing everything via telehealth, which we're not allowed to consider in our network adequacy standards. But it's hard to find behavioral health providers who are not doing psychiatric treatment or psychological treatment via telehealth services. So it's that's considerably less overhead cost than it would be for a medical surgical office that has to have patients come inside.
All right. I think Dan had his hand raised, and then we'll move to Melissa.
Just wanted to respond to a couple of the points that Melissa made. One, not wanting to lose the information about who has negotiating power and who doesn't. And I think you will find that in the incurred claims rate, because the providers who have negotiating power are not going to be providers who didn't send in any claims. Those are, you'll get that information about the deviation from that standard and who, how much deviation there is and how wide it is from the incurred claims. And then also just wanted to point out that when it comes to negotiating power, the having it or not having it or negotiating up or not negotiating up based on the amount of negotiating power that the person on the other end of the table has isn't a parity violation. So large hospital systems have more negotiating power than an independent practitioner. And that's true medical as well as behavioral health. And that's not a parity violation. So I think we need to keep that in mind.
Melissa.
Yeah, we're really getting in the weeds here, and I'm really glad to hear that Tasha is going to be having some more conversations with insurers about how we can look at that data. But I just want to get back to the original discussion that we were having when we were debating between looking at incurred claims versus contracted rates. Is we just want transparency. We just want to be able to see everything and look at what is going on there. And if we don't find anything that is relevant to network adequacy, for instance, then there seems to be some space in the future for the reporting requirements to perhaps evolve. But all that we're really asking for is transparency and being able to look at all of the data, and that may be useful. And I look at the other argument, which is it's too difficult to obtain the data, so therefore let's not look at it. And I'm just not sure if that's a good enough argument. I'm just advocating for transparency and access to all the data.
All right. In the interest of time and moving on to brief discussion about out-of-network providers, hopefully this is helpful in terms of talking with the other RAC members. And like Tasha said, I think we'll meet individually with insurers to talk about kind of specific concerns and what we can do about that, with also keeping kind of transparency in mind and the other things that we as regulators also need to look at in terms of making sure that there's network adequacy and whatnot. So thank you all for a robust discussion. And obviously, if there are further comments about this, feel free to send them my way, or there will also be an opportunity to talk, provide testimony at the public hearing next week on our proposed rules. So moving on briefly to the out-of-network providers, Dan, I know you brought this up in terms of the reporting, and perhaps there's a way that we can clarify it so they're separated out, like you mentioned, and not intermixed, and perhaps that will just solve the issue. But wanted to give an opportunity if other members had thoughts about that as well before we move on to really the main course, the meat and potatoes of all the other sections of House Bill 3046. All right, not seeing anyone who wants to jump in, so we'll take that back and kind of work with the data template to make that a little bit more clear in terms of how that's to be reported. Okay, so moving on to the main show of this bill. Well, I sort of thought that we could start with Section 5 and start working our way down. I don't think we'll get through the whole bill today. And so we'll likely schedule some meetings in January before session, just so we can have at least some pretty robust initial conversations, and that'll give us a good basis to be thinking about what we need to consider for rulemaking, with all of your expertise and information in mind. So starting with Section 5, want to open up a conversation about definitions. In some of the comment letters, we heard about specific phrases that would be helpful for us to clarify in rule, or in the statute, it says that it has a meaning that we will prescribe by rule. So want to open it up to hearing about if there is anything specific. I think the first one is behavioral health condition. And I think, we looked at or so there were comments about specifying CPT codes, or perhaps there are other ways of doing that. So want to hear from you all about kind of if there are things we should consider for that definition. And Lisa, feel free to jump in.
Thanks, Cassie. Yeah, a lot of screens open here. For this particular in section 5, 1B, it says behavioral health condition has the meaning prescribed by rule by the Department of Consumer and Business Services. And we do have a rule that exists that just needs to be use the appropriate terminology within the rule, but it outlines that a behavioral health condition is defined by, it means any mental disorder covered by diagnostic categories listed in the, listed in the Diagnostic and Statistical Manual of Mental Disorders, DSM, got my Roman numerals right, 5TR, et cetera. So just wanted to mention that before we continue the discussion on that definition.
That is a great point that we do have that in our rule. Tim.
Can you guys hear me?
Yes, we can hear you.
There we go. Okay, sorry about that. Yeah, so I also was going to bring up that other rule that you guys have and mention that, and I would say, I would think it would make sense to either say, I think you see a number of states, other states have, when it comes to this defining behavioral health condition or mental health or substance use disorder, you go by as it's defined in the DSM or in the ICD-10, the International Classification of Diseases, the mental and behavioral disorder section. I would recommend probably doing that, or just importing the rule you already have that has clarified the definition of behavioral health conditions.
Dan.
Remembering back to the history of this bill, there was a different definition of behavioral health condition in the introduced bill, and we argued that we already have a good definition in rule and we should use that, and I think that's how we ended up with this language. So I would support using the current rule.
All right, Bennett.
Yeah, thanks. I haven't read the rule, but you called it DSM-5 TR. So it's DSM-4 TR or DSM-5. And I know that there's sometimes a lag between updating rules and statutes to reflect the current taxonomy. And all I would say is it ought to be the most recent iteration of DSM or ICD. I myself would go with DSM-5 because ICD-10 is not the most recent iteration of ICD, the one we use in this country, and so that may lead to some confusion, but not a big deal.
Dan.
That's a great point, Bennett. The current rule says 4 TR or 5, and I think it would be great to get rid of the 4 since that's obsolete now.
Jen.
I was just gonna say I agree with Dan. Let's use the current definition, and I agree to take out the 4 TR. That's fine.
That all sounds good and makes a lot of sense. I think the rule that we do have has some terminology that we'll need to update and kind of go through as kind of just a pro forma look at the terminology that's used and update that when we move forward with the rulemaking. But thank you all for those comments on behavioral health condition. The one other definition that we heard from Rachel about the timely delivery of service, and we can talk about if there are other definitions that need to be added to this list, but want to open that up for conversation in terms of how to better define or clarify pieces of this section. And Karen, it might not be listed in the definition it's in the statute. I think it's just a term that we might need to provide some clarity in rule.
All right, thanks.
Yep.
I would just note the proposal for 2 weeks is consistent with NCQA standards, so that would seem like a reasonable proposal.
All right. If there's not any other thoughts in terms of that definition, I'll open it up to hear from RAC members if there are other terms that need to be defined, or if I missed anything in the list. I'm sure there will be others that come up as we continue our conversation, but if there's anything that pops out right now, would love to hear about it. Okay, so we'll move on to part of Section 5. It requires that we establish some parameters for what a violation would look like for this section. I think we did receive some comments from, I think it was Melissa, about the violations and kind of what that would look like. But want to hear if there are other thoughts from RAC members, other things that we should be considering as we move forward with this language. We will be working with our compliance and enforcement staff on the DFR side to make sure that the language that we do put in rule is consistent with kind of other enforcement and compliance language that we do use in other aspects. Any thoughts about the violations? All
Gary,
right.
you're muted. Sorry.
There, how's that?
Works great.
All right. So, hey, what I was trying to do is, can you give me a little bit more about the issue with violations? What is the concern? I'm trying to understand that.
Oh, so there's no concern. The language in the statute says that we will adopt rules making it a violation of this section. So if there's anything that we should be considering in terms of that rule language, which I know it's probably a little bit difficult to have a conversation about this without proposed draft kind of rule language, but as we start thinking about what these rules look like, if there are things that we should consider from your perspective, we would love to hear about it before we start putting together rule language, and hopefully that'll avoid some issues.
Are you thinking of alternative ways to enforce than just?
Not necessarily. I think Melissa did a good job outlining some considerations for violations. Like, I think it would be helpful to hear if, some specificity is helpful in terms of what that language looks like, or do we make it broad? Would just love to hear kind of some general reactions in terms of we have throughout kind of all of our regulations, we've got some laws that are more specific and have specific violations that are kind of broader categories that are called out, or we leave it as just a general kind of catch-all.
Okay.
And if there's not thoughts now, like I said, I think probably will be helpful to have some draft language to look at and react to in the future. Tim.
Yeah, so, and I would raise my hand before you said that you do have certain laws or provisions that have specific, more specificity around violation enforcement. I mean, to me, just working with a lot of state insurance departments, I mean, I would just go with making it the same as any violation of the insurance code that is, under that general, chapter or title or subtitle or whatever within the insurance code. So if any violation of this code, blah, 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 blah. But that you do have you just said that you do have some specific specificity beyond that. Maybe this would warrant that as well. So I guess maybe it'd be best just to see what you guys put together and what that might look like.
Thank you. So with that, before we move on to other parts of the bill, is there anything else with Section 5 that we should be thinking about in terms of rulemaking? Gary.
Hey, yeah, what I want to do as my comments earlier is understand the subsection 5 of Section 5 that talks about this formal education program. We've had questions internally. The bill's kind of broad in there, and I'm trying to understand, is that going to be how we want to take this approach, is broad in language, or do we want to firm it up and say, what constitutes a program? Does it have to be approved? Who can do it? What is sponsoring? Those types of things. I don't know what the intent was of that area, so that's why I'm asking. I don't know if other RAC members have an idea of what this formal education program is to look like. So just appreciate comments in that area.
Rachel.
Thanks. Gary, I will respond to that question since I was a part of those conversations, recognizing that my brain did an amazing job of dumping session out the moment it ended. And that we had a coalition member who is specifically focused on this portion of the bill. So I'm going to need to consult with them to provide you better detail. But I think the intent was sort of to leave it broad in the bill so that we could have a very specific conversation in this group as to whether or not it made sense to be more specific in rule, or if we could develop a good enough understanding that we didn't need to be. So let me go back to my coalition member, and I can provide some written, or have them provide some written comments about sort of the what we would like to see out of this rulemaking process for that specific section, recognizing that it was but one of many things that were negotiated during this bill, and I don't have any more specifics than that. My apologies.
All right. Thanks, Rachel. The reason is because we've had another bill go through where there's supposed to be a program approved by a state agency, and it's caused us a lot of heartache and some confusion there. And it also causes, I think, unwarranted delays. And so that's why, if we can understand, is it want to leave it broad and let the carriers define it, or whatever it may be, and what is considered sponsoring, I'd appreciate that.
Yeah, I appreciate that background.
Dan.
I do recall during the negotiations around this bill, insurers asked that, well, when we asked about the intent behind this, the intent, I think, was to mirror something that had happened as a result of WIT. And we were told the intent was that this be a one-time requirement. We asked that be made explicit in the bill, and we're told it's not necessary to have that explicit in the bill. It's understood that this is a one-time requirement, and I'd like to make sure that understanding carries forward into the rulemaking process.
I'll jump in really quickly. I remember that conversation, Dan, as well, and apologies for not remembering it when I talked previously.
No
Hey, Dan, what do you mean by one time? We only have to do it once and that's it?
Yeah, it's around when we adopt the, so we're going to be required to, adopt locus and cal locus. And so the idea is to not only make sure that our own staff are trained in those tools, but also make that training available to the broader provider community. There's also going to be, I'll digress a little bit here, an interesting dynamic in that requirement that we use those two tools was originally in the bill for both Medicaid and commercial. and it was taken out for Medicaid but left in for commercial. And that could create some interesting dynamics in terms of our relationships with our providers.
Okay, do we know who, is there an idea of who that specialty association is already that's going to be doing this? The nonprofit?
Yeah, it's AACP that develops and maintains the CalLocus, and then probably somebody else, probably the psychiatrists that maintain the locus.
Okay, I appreciate that. I hadn't heard any names yet, so.
And just to quickly clarify, Dan, so locus and CalLocus are tools, but could you explain those a little bit better for my understanding?
Sure, those are level of care tools. So yeah, one of the issues in WIT was that the defendant, UBH, was using medical necessity criteria that were more stringent than the community standard of care. So what's the community standard of care? And they decided that the locus and CalLocus were pretty good basis for understanding what the community standard of care is for level of care decisions.
I believe that also, right, this is Chris, we don't want to leave out the ASAM from that conversation either.
Right, agreed completely.
And I'm assuming ASAM is just another level of care placement tool that's utilized. Okay.
Well,
I'm seeing nodding.
It's for addictions. It's the
Okay.
American Society of Addiction Medicine. I just, the other thing I would just point out is that I've had some conversations for other reasons. The people that do the education for the locus right now is an outfit called Deerfield. I don't think they're nonprofit, but they're the licensing body for the American Association of Community Psychiatry. And so you got this weird thing when you're required to have a nonprofit organization that it's the same people that do it, but now it has to go through AACP. I don't know if there's a way to, I don't know how big a deal that is, but it sounds like it's unnecessarily convoluted to get the same result.
Thank you all. That is helpful for my understanding. And Rachel, you have your hand raised. Is that to continue, or is that from before?
No, I just, Teams and I, you know.
Yes, yes, we've all been there with our lone hand up. All right. Thank you for that conversation on the education programs. I know that was helpful for my understanding, and I'm sure it was helpful for others as we think about what needs to be clarified in rule. And we'll certainly think about, Bennett, you brought up that there's kind of this roundabout way of getting at a nonprofit, but it's the same education program. So I think we'll do some thinking about that as well. And whatnot. And Rachel, will look forward to kind of hearing back from you in terms of if there's any other pieces of information around this that would be helpful for all of us to know, and kind of considering what the rules look like. Gary.
Yeah, just one other thing is the timing of this. As with everything, it's, since we're still developing this, what we want to think about is the rules, when we're going to want to require this of the health plans. It may be one thing to sponsor it, but to actually implement it and get people trained, maybe a different timeline or a modified one. So one other piece to throw out there.
Thank you. And I think you mentioned, or someone mentioned, that the intent was a one-time training. And I guess for my clarity, is this a one-time training for the individual employee that will be kind of overseeing this tool, or is it a one-time training for the staff overall? I'm more just thinking of and I know technology will likely change and whatnot, but for continuity's sake, say you have a lot of turnover of staff, at what point do you retrain folks if that does happen? or perhaps there's a new tool. I don't know. I guess I'm trying to think of like the future in terms of, yes, you could have this training one time, but then if there are reasons why you should probably engage in it again, we could put that kind of clarity of like, if these criteria, or kind of leave it vague, but provide that opportunity if it seems prudent to go through that training again. Dan.
Those are good questions. I think again, looking at where it came from, coming from WIT, the idea was to provide it once to everybody, to bring everybody up to the same baseline. And then, of course, we would have a responsibility to maintain competence in those things. And I think that's addressed in the law somewhere as well. But that particular requirement in the statute is fulfilled once we do that once.
Rachel.
Yeah, I just wanted to echo that, agree with that, and say that it was a clarification that carriers are not responsible for training their employees on a yearly basis on these tools, that you get folks up to speed. And then I think we're more than happy to have conversations around if we need to include some fuzziness to allow for continued sort of compliance and expertise, but agree with Dan's perspective on this.
Great. That clarity is helpful for me, because those were kind of the questions that came up with one time. What does one time mean truly in terms of kind of that education piece? So that is helpful. Thank you. All right. Before we move away from section 5, anything else that we should be thinking about or considering? All right. We will move on to section 6. This section has a lot of the network adequacy provisions around mental health and behavioral health providers. And I know there's a lot of kind of thoughts about this in terms of kind of what should be required, how we should look at network adequacy. Kind of want to open it up and see if there are subcategories. I know we've brought up the piece about the LGBTQIA community, and including those folks, that community, within some of our rulemaking language, but want to see what other aspects should we be looking at, or are places where you all think that clarity would be beneficial. Dan.
So the statute calls out counselors, marriage and family therapists, social workers. One thing I would recommend is that those 3 types of providers be treated as one, that we don't have a separate standard for counselors and then a separate one for LMFTs and a separate one for LCSWs, since functionally those 3 categories of providers, and I speak as one of them, an LPC, we do the same thing. And so I would lump the 3 of us together in terms of how we're able to account for that.
Okay, so that was LPCs, LMFTs, and LCSWs, or was that the 3? Okay, great. I just wanted to make sure I got my acronyms and professions right in my notes. Melissa.
Just looking here, a member of my group keeps bringing up that we want to make sure that psychiatric nurse practitioners are included. And I'm not sure how that works. Maybe one of the insurer representatives could provide clarification on whether they could be grouped with psychiatrists or whether they need to be a separate category.
We should get a psychiatric nurse practitioner and a psychiatrist to duke it out on that one.
Bennett.
Well, I'm not going to wade into that, but every time I see this, I wonder what the geographical distribution means, whether that is distance from where the patient lives, how telemedicine figures into that. I just wonder if if there are any thoughts about how that's going to work.
Chris.
Yeah, just to the question of psych nurse practitioners and psychiatrists from the user perspective or the member perspective, the issue is being able to access a qualified prescriber. So however that's sort of defined, that's from our perspective, that's the most important thing, is making sure that there's enough prescribers on a panel with this particular expertise given our conditions.
And perhaps this is an area where we can do some digging ourselves, but you know, there's probably some tension around psychiatric nurse practitioners and psychiatrists where they fit based on some of the comments. But does anyone know if other states have kind of some specific ways that they group these different practitioners with each other, or separately for that matter? That might be a helpful place for us to look. And if no one knows, that's okay. That's part of what we can dig into as one of our follow-up items for you all before our next meeting, is to look into if there is any kind of guidance in other states. All right. I think I want to circle back to what Bennett brought up about how geographic distance will work, especially with telehealth, and see if there are there ways that insurers are currently evaluating and integrating telehealth into kind of that calculation, or what does that look like? And I figured Tasha would jump in as well, knowing all about our network adequacy reporting and how that looks. So Tasha, take it away.
Actually, I just wanted to point out that this will be changing, or did change a little bit over the summer. And most of our insurers do not generally use telemedicine to meet network adequacy. There were a small number of insurers in Oregon that did and have had to make adjustments to their network in order to meet the network adequacy requirements, now that telemedicine can't be used as part of meeting that requirement. The one thing that I would say is that one thing that we are really struggling with in Oregon, and I think most of our providers on the line know this, is just lack of access in certain parts of the state where telemedicine may be the only available option in terms of seeing providers with certain specialties, or that are conscientious and understanding of like LGBTQ issues, stuff like that. So while telemedicine cannot be used to meet network adequacy standards now, this is something that I'm following, and the geographic distribution question is something that I'm very interested in following, Bennett, just so you know. But that is something that I'm also monitoring from a telemedicine standpoint.
Bennett.
Yeah, I haven't looked at the map for a while, but as I recall, in terms of the way the state's divided, Hood River is in the same geographical region as Burns. I may be wrong about that, but there's huge. And for a patient living in Burns, how many people are in Hood River is meaningless. So that's why I think we need to be practical. And I lived in Astoria for 7 years, and I think the North Coast is one geographic region, and it's a long way from Astoria to Tillamook, for example. I mean, it's. So I just think if we're going to do this, we really need to think about how we're doing this, and the regions can't be so large that they become meaningless for the person that's needing the service.
So no, that's a great point, Bennett. And he's not on the call right now, but 2 years ago now, we did look at the geographic breakout of our state because the bill references back to our existing geographic distributions. And we went and did a lot of work with the insurers and with an actuarial firm that we contracted with for that to look into readjusting the geographic areas to, I guess, be more reflective of what population distribution looks like today. And after looking at it a couple of years ago, we said now wasn't the right time because of COVID and a whole bunch of things happening. Now, I'm not saying, like we said, that we needed to come back to this in a couple of years once things settled back down. And that is fully our intent, because this is something that comes up not just from a provider standpoint, but also from an insurer standpoint, because access to medical care is very different for folks who live in Hood River than for folks who live in Burns. So I actually grew up in Burns, so that's why I feel comfortable using it as an example. I throw my family under the bus all the time. But something that does come up routinely from more rural neighborhoods that I think plays into especially mental health is that a lot of times people don't want to see a mental health provider from their own community, because in those small communities, people don't want to be seen in the mental health provider's office where other people will talk, stuff like that. So as we're looking at geographic distribution, one thing that I am hyper aware of as I monitor network adequacy and mental health is striking that balance between, close in-person access, excuse me, and making sure that folks do have access to providers that they feel like they can see confidentially, I guess. I don't know how else to say that. But in small communities, that's really hard. So definitely, as we look at those geographic areas, just know that I know they're set now and we're kind of stuck with those, but that is something that from an actuarial perspective, the carriers are aware that that's something we're looking at, and that's something we constantly struggle with.
Dan.
Just a little bit of background in terms of a couple of the ways that that we do measure geographic distribution. Historically, at MODA, for behavioral health providers, we went county by county. So we said, in each county, we want to have this many behavioral health providers for each member, or this ratio of behavioral health providers to each members, and then we broke that down by psychiatry and therapy and psychology. And NCQA came back at us at one point and said, well, that's actually not geographic distribution, that's number of providers. And there are tools that we use that will calculate, or will show where your population is and where your providers are, and then they'll spit back results for you. You'll say, 99.5% of your members in an urban area have access to a psychiatrist within 10 miles. And there's different standards for urban and suburban. I think it's just 3 categories, but something urban, suburban, rural, frontier, some mixture of those kinds of things. And so look by those categories, and then then they'll also, it'll spit out a map for you and show you where your areas of weakness are and strength.
Go for it, Tasha.
So Dan, just a question, and this may be a question for others as well, but on those factors from the CMS tool, I know what you're talking about. I also can't remember the distribution points, but I can bring that back for next time. One of the things that I am thinking a lot about is given the change in climate and that we had large portions of our state blocked off by wildfires and treacherous roads. One of the questions that I've started to ask insurers as part of network adequacy reporting, and I think should be brought in here, is in the event of a weather emergency or weather or climate issues, natural disasters, how does the mountain range, the Cascade Mountain Range, fit into those calculations? And is that something that we need to, as we're doing rulemaking for the division, look at? Sorry, Cassie and Lisa and Brooke, that is not something that I anticipated asking today. So apologies if this takes us down a different rabbit hole.
Thank you for your help.
And I know we're coming up on time, not to leave it on that note, but I think it is an important consideration, as we have had several kind of unfortunate natural disasters or disasters that we've just been faced with that do impact networks, to be part of kind of an evaluation or calculation and considering what those networks look like. So we will continue that conversation. Want to pause here. I know we didn't get to one of the big topics of conversation, which is the utilization review and the criteria and tools that are used to determine that. But want to just provide an opportunity if there are members of the public or other interested parties that would like to provide any public comment at this time. Feel free to raise your hand. Okay, I am not seeing anyone hopping on the opportunity. If you are an interested party or a member of the public, you are welcome to submit written comments to myself, Lisa, or Karen that we can send along to the RAC for their consideration. In terms of wrapping up, I think there's a few more kind of big topics for us to talk through and at least get some initial, have some initial conversations. I'm sort of thinking that we'll schedule one more RAC meeting to happen in January before legislative days so that we can at least have the opportunity to hear about all the pieces of rulemaking that we should be considering, so that when we come back after March, we can continue a robust discussion and have some draft rules that you can all look at as well as we continue this process. So the one other thing that I want to bring to your attention, and I mentioned this at the beginning of the meeting, the public hearing on the reporting requirement rules will be December 17th. That is a Friday and it's right before the holidays, but that was the best date that we could find that provides adequate notice to the public. So feel free to join us and provide further comments on those rules. We will go through that kind of formal process and we'll look at and evaluate the comments that we get back and let you all know if there are any kind of minor changes that we might make to the rule in response to that. Any other items that folks want to bring up before we wrap up? All right. Thank you all. I appreciate the kind of initial conversation into our next phase of rulemaking. If it is helpful, we can set a kind of a timeline to provide comments before our next meeting if other things pop up or you have some conversations about areas that need to be clarified. Feel free to email those to Lisa and I, and we'll make sure that we take a look at that, and we'll be in touch with the next meeting. It'll be probably in January after the holidays before legislative session, and we'll try to pick a time that's not during ledge days either. Melissa.
I just had a question. I didn't quite understand. Are you saying that you're expecting to have some draft rules out before our next meeting in January?
I don't think we will have draft rules before January. I think the goal is we'll continue this conversation, and I think there'll be some significant conversation about the utilization review tools and the other criteria and guidelines. We may not use the full hour and a half, perhaps we will, but that'll give us a good kind of roadmap of what pieces we need to look at to clarify for draft rules that will circulate before a March meeting. February is going to be a crazy month for, I imagine, a lot of us with legislative session. So we will likely skip meeting that month just because, yeah, it will be very busy. Does that help, Melissa? Okay, great. All right, thank you all. I really appreciate the comments that we got this time, and we will make sure to do some follow-ups with you all, particularly the insurers. We'll be meeting with you all about the reporting template. Do someone raise their hand? I don't know if you needed a question or not. Okay, we will wrap up. Thank you all. Have a happy Tuesday. Bye, everyone.
Take care. Thank you.
Yeah. Bye.
Bye.